بسم الله الرحمن الرحيم وبه نستعين. Assalamu alaikum everybody. I hope you are all well and in good health and prosperity. Today is the third presentation about diuretics, and we will speak about thiazide and potassium-sparing diuretics. I have to mention that revision is necessary for the first lecture of diuretics in order to understand what are the sites of action of thiazide and potassium-sparing diuretics. The fourth group we are going to talk about are the thiazide diuretics. This includes many examples, most famous chlorothiazide, and this is the only thiazide which is used for parenteral administration. Others that are given orally mostly, and this includes hydrochlorothiazide, chlorothalidone, and indapamide. These drugs they are given orally. All the thiazide diuretics are sulfonamide in structure. Therefore, we expect that they will produce allergic reactions, especially with people who are allergic to sulfonamides. These drugs usually kinetics, they are secreted by the organic acid secretion system in the proximal tubule, and therefore you expect that they will compete with uric acid on secretion in the proximal tubule. That means that they will prevent excretion of uric acid, and this will result in hyperuricemia, as we will say later. And they act specially by blocking a special transporter in the distal convoluted tubule, which is the sodium chloride transporter. So just imagine this is the distal convoluted tubule, which contains the sodium chloride transporter, co-transporter. So what will happen in this case? Sodium and chloride ions will be delivered in the urine, and by this co-transporter they will be absorbed into the distal convoluted tubule. Okay, now once they are sodium and chloride, they are inside the distal convoluted tubule, sodium will be exchanged with potassium using the sodium potassium pump. So potassium will be enter into the distal convoluted tubule, while sodium will be reabsorbed back into the general circulation. Okay, now in this distal convoluted tubule there is another hormone, which is the parathyroid hormone. This parathyroid hormone is responsible for the formation of calcium channels in the lumen of the distal convoluted tubule, and these calcium channels will allow for the reabsorption of calcium from the urinary filtrate. Okay, once calcium enters the distal convoluted tubule, it will be exchanged for sodium by the specific sodium calcium exchanger, which is present in the basolateral membrane of the distal convoluted tubule. Okay, so calcium will be reabsorbed back into the general circulation in exchange for sodium. Okay, now sodium, as we have said, will be exchanged with potassium using the sodium potassium pump. So we expect that the reabsorption of sodium will be accompanied by loss of potassium. That means potassium will be excreted. Once potassium is excreted, its level in the blood will be decreased, and this is known as hypokalemia. So this is what will happen. The thiazide diuretics, by inhibiting luminal sodium chloride co-transporter, these co-transporter, they produce several physiological effects. So by inhibiting this co-transporter, first thing, we inhibit the absorption of sodium and water. So sodium will be excreted, and as well water. This will produce diuresis. Produces diuresis. Diuresis is not very strong diuresis, it is a mild diuresis, okay? Once sodium and water is excreted, this will lead to two physiological phenomena. The first, by increasing excretion of sodium and water, by producing diuresis, that means blood volume will be decreased. Blood volume will be decreased. If blood volume will be decreased, that means the venous return to the heart will be decreased. The volume of the blood which returns to the heart will be decreased. This is known as preload. Therefore, first physiological phenomena that will be done by this inhibitor of the transporter is decreasing the preload. Second, by decreasing the sodium concentration in the smooth muscle of blood vessel, the blood vessel becomes less reactive to stimulation. That means vasodilatation. Blood vessel will be dilated. That means there is a decrease in the afterload. Okay? So by decreasing the sodium level, the smooth muscles of the blood vessels will becomes less reactive. That means they will be dilated, vasodilatation. If this takes place in the arterioles, this will lead to decrease in the afterload. So by decreasing the afterload and decreasing the preload, this has a beneficial clinical effects, where both in controlling blood pressure, okay, so they will decrease the blood pressure. These drugs, by inhibiting this transporter producing diuresis, they will decrease the preload and the afterload, and therefore they will decrease the blood pressure. That's why thiazide diuretics are first line drugs in treatment of mild hypertension. Sometimes they are used alone in mild hypertension. They are effective in decreasing the blood pressure in mild hypertension, and in moderate hypertension usually they are mixed with other drugs, group of drugs like ACE inhibitors, like calcium channel blockers, etc. Okay, so this is the first clinical application of the thiazide diuretics. They are used in treatment of mild to moderate hypertension, either alone or in combination with other groups of antihypertensive drugs. Second, they are of important clinical application in treatment of heart failure. Why? Because as we have said, by decreasing the venous return and decreasing the venous return, that means decreasing the preload and decreasing the afterload, that means the heart will work against lower resistance. Once it works against lower resistance, heart performance will be improved. Therefore, cardiac output will be increased. This is one. So they are used in heart failure. Why? Because by decreasing the afterload and decreasing the preload, they will decrease resistance against which the heart works, and this will improve the performance of the heart, increasing cardiac output. Okay, this is one. Second, by producing diuresis, they will decrease the edema, which is usually a common feature of heart failure. They decrease edema, especially pulmonary edema, which is a common feature of heart failure. Okay, so that's why thiazide diuretics, they have very important clinical application in treatment of hypertension and heart failure. Okay, so this is the first. By increasing sodium and water excretion, they produce diuresis, and they have very important clinical application for this reason. Second, they decrease the sodium in the distal convoluted tubule. As we said, by inhibiting the transporter, the sodium inside the distal convoluted tubule will be decreased. This will produce a reflex increase in the sodium calcium exchanger. So this calcium sodium exchanger will be stimulated, means that they will increase the reabsorption of calcium. increase the reabsorption of calcium. Okay, this is very important because the first loop diuretics, they produce the opposite effect. They prevent the reabsorption of calcium, as we have explained before. Here it is the opposite. So by decreasing the sodium in the distal convoluted tubule, they will stimulate reflexly the sodium calcium exchanger. This will favor reabsorption of calcium. So calcium will be reabsorbed. Renal tubule, calcium levels in the renal tubule will be less, increasing calcium reabsorption. Okay. Last thing, by decreasing sodium in the distal convoluted tubule, they will increase the excretion of potassium. They will increase the excretion of potassium. This will result in what's known as hypocalcemia. Sorry, hypokalemia. Hypokalemia, which is usually dangerous because, as we know, potassium is important for the inhibitory effect on the heart. In this case, arrhythmia might ensure. So these are the general actions of the thiazide diuretics. So what are the major side effects? They have other side effects. At first, as we have said, they produce hypokalemia due to loss of potassium, and this is sometimes dangerous in people suffering from cardiac arrhythmia. And as well, they will lead to the loss of proton in the urinary filtrate. Proton is the hydrogen ion. In this case, this will produce what's known as metabolic alkalosis. Metabolic alkalosis, because loss of proton from the blood, this will result in blood pH will be increased, producing metabolic alkalosis. We will discuss that in details, inshallah, in a few minutes. The second, they will affect the insulin release. They affect the insulin release from the cells of the pancreas. So we expect that they can produce hyperglycemia, especially in diabetic patients. So diabetic patients, they are very sensitive to any change in the insulin secretion. Therefore, by inhibiting the insulin secretion, they might aggravate hyperglycemia, especially in diabetic patients. As we have said, that they are secreted through the organic acid secretory system, and they compete with uric acid on this system. That means they will inhibit excretion of uric acid. This will produce retention of uric acid in the blood, i.e. increasing levels of uric acid. This is known as hyperuricemia. Hyperuricemia is dangerous sometimes in cases of gout. So people who are suffering from gout or gouty arthritis, they should not be given thiazide diuretics because they might aggravate gout. Also, they can produce hyperlipidemia, retention of lipid in the blood, and this will result in hyperlipidemia. As we have said, thiazide diuretics, they are sulfonamide in nature, and as we have said that many people, they are allergic to the sulfonamides. That's why sometimes people, they can get allergic reaction in response to thiazide diuretics. The fifth group of diuretics are the potassium-sparing diuretics. These diuretics, they are known as potassium-sparing. Why? Because they increase the excretion of sodium and they prevent the excretion of potassium. That's why they are known as potassium-sparing. Where these drugs act, they act on the collecting tubule of the nephron. As we know, the collecting tubule is the major site where most of water and the last traces of sodium are absorbed. As we know, in the collecting tubule, aldosterone, which is secreted from the adrenal cortex, which is a mineralocorticoid, and as we know, aldosterone is under the control of the angiotensin-renin system, aldosterone will enter the principal cell in the epithelial cells of the collecting tubule, where it will bind to specific aldosterone receptors which are present in the nucleus, and this will result in the expression of new genes, and these new genes will lead to the synthesis of new proteins which are usually sodium channels. They allow the entry of sodium, potassium channels, and as well aldosterone will lead to the formation of the sodium-potassium bond. Therefore, increasing aldosterone will increase the expression of the sodium and potassium channel, and as well increase the expression of the basolateral sodium-potassium bond. So what will happen in this case? Aldosterone will increase the reabsorption of sodium. Sodium will enter the principal cell from the urine, and once inside in the principal cell, sodium will be exchanged for potassium by the effect of the sodium-potassium bond, as we know, and potassium will leak out in the urinary filtrate. Therefore, aldosterone will increase the reabsorption of sodium and as well water in return, and will increase the excretion of potassium. Okay? Now, this happens in the principal cells. In the collecting tubule, there is another type of cells which are known as the intercalated cells. In the intercalated cells, on the luminal side, there is the proton pump. Okay, this proton pump is responsible for the pumping of the proton out into the urinary filtrate. So what will happen in this case, as we have discussed before, water plus carbon monoxide, which are present in the cell, under the effect of carbonic anhydrase enzyme, will form carbonic acid and proton. Carbonic acid and proton. Proton will be bumped into the urinary filtrate under the action of the proton pump as we have described. Carbonic acid will be exchanged on the basolateral membrane by the carbonic acid chloride exchanger. Chloride will diffuse back into the general circulation. So what will happen if we prevent the effect of aldosterone? In this case, we have two groups of drugs. The first group, they are steroidal in nature and includes the most famous examples, spironolactone and eplerenone. These two drugs, they are aldosterone antagonists. They are competitive antagonists at the aldosterone receptors in the nucleus of the principal cells of the collecting tubule. Okay? So these drugs, they are steroids in nature and they block the aldosterone receptors, and therefore they prevent all the actions of aldosterone, including their effect on the generation of new proteins like the sodium potassium channels, the pumps, sodium potassium pump, and the proton pump. The second group, they are specific, they are non-steroids, and they are specific in blocking the sodium channels. They have nothing to do with the aldosterone receptors. This includes two famous examples, amiloride and trimethoprim. They are non-steroid, and therefore you expect that they are devoid of any steroidal effect, and all their action is to block the sodium channels which are present on the luminal membrane of the collecting tubule. Okay, so what will happen in this case? These two drugs, when they act on their site of action, they increase the sodium clearance, of course, because By blocking aldosterone receptors, no sodium channels and no potassium channels will be formed, and sodium will not be reabsorbed again. So what will happen? Sodium will be excreted. So this will result in increased sodium excretion or clearance. On the contrary, potassium will be retained. Potassium will be retained because not will be excreted. So potassium will be retained. As well, proton will not be excreted. So proton will be retained. Okay. So these drugs, they will cause increased excretion of sodium and decrease the excretion of potassium. That means potassium will be retained in the general circulation, their level will be increased, and they cause the retention of proton as well, of the hydrogen ion. That means acidity of the blood will be increased. So what will happen? By increasing the excretion of sodium by these drugs, which are known as potassium-sparing diuretics, they will produce diuresis. So this is the first clinical application. They are used to induce diuresis in certain cases. Like for example, they are used when diuresis is needed in the treatment with digitalis, like digoxin, as we will discuss later, inshallah. So they are used as diuretic in cases of use of digitalis. Why? We'll explain that in details later, inshallah. Also, they are used as diuretics. Usually, they are added with the other types of diuretics like thiazide diuretics and loop diuretics, because these drugs, as we have said before, they cause hypokalemia. They increase the excretion of potassium. Well, hypokalemia is dangerous sometimes. So usually they are combined to avoid the hypokalemia induced by the thiazide and the loop diuretics. Usually they are combined in the same preparation. Okay, so this is one. They are used in certain cases of clinical condition to induce diuresis. Of course, these drugs, as we have said, they cause retention of potassium. Potassium will not be excreted. That's why they are called as potassium-sparing diuretics. And once they cause retention of potassium, they will cause hyperkalemia. They will cause hyperkalemia, increase potassium level in the blood. Hyperkalemia is dangerous sometimes. Why? Because it can cause cardiogenic arrhythmia. It can cause cardiac arrhythmia, disturbance of the cardiac rhythm, because potassium is inhibitory to the heart. It can cause dangerous cardiac rhythm. So this is usually a side effect, and sometimes it is used when there is a hypokalemia. Okay, these drugs as well, we said they will cause retention of the proton because of the inhibition of the proton pump, and the retention of the proton, retention of hydrogen ion in the general circulation will cause acidosis, will cause metabolic acidosis. Okay, so in general, these drugs, they are used as diuretics, and they can cause hyperkalemic metabolic acidosis, very common side effects of these drugs. The other thing that spironolactone, this is a steroid antagonist. It can block an androgen receptor in males especially. It can block aldosterone receptor and plus the androgen receptor. Androgen receptor, which are the receptors responsible for the sex hormones, and this will result in what's known as gynecomastia, which is increase in the breast size in male, which is very, very annoying side effect. So these drugs, by blocking androgen receptors in the body, especially in male, can cause gynecomastia. Also, they can decrease libido because they block androgenic receptors in male, and they can produce decrease in sexual desire. Okay? These drugs, they act by the same mechanisms nearly of the angiotensin receptor inhibitors and angiotensin receptor antagonists, and usually they should not be combined together. They should not be combined because, as we have described in previous presentation, angiotensin converting enzyme inhibitors, they can cause hyperkalemia, and as well the angiotensin receptor antagonists because they prevent the aldosterone effect. So they can increase the hyperkalemia induced by potassium-sparing diuretics. So, this combination usually is not favored at all. Okay, they should never be combined because both of them, they will potentiate their effect on potassium excretion, producing very severe hyperkalemia. So they should not be combined. Lastly, they are usually given with digitalis because when we use other types of diuretics with digitalis, they can cause hypokalemia, and the hypokalemia can increase toxicity of digitalis, as we will describe later, inshallah, when we talk about drugs which are used in treatment of heart failure, and especially digitalis. So usually in this case, digitalis, if diuresis is needed in people who are given digoxin, for example, in this case, we favor giving them potassium-sparing diuretics like spironolactone or amiloride. Okay, so this is generally potassium-sparing diuretics. So, in summary, we have talked about the thiazide diuretics. We said that they have a primary role in treatment of hypertension, where they are used for treatment of mild hypertension to moderate hypertension, either alone or together with antihypertensive drugs. We said that they have as well a first line therapy in certain types of congestive heart failure, and we have explained why. Also, they are used in certain cases of diabetes insipidus. The last group we talked about are the potassium-sparing diuretics, and we said that usually these drugs, they are combined with the other type of diuretics, which are the thiazide and the loop diuretics in treatment of hypertension, in order to decrease the hypokalemia induced by thiazide and loop diuretics. Potassium-sparing diuretics are the favorite diuretics, especially when digitalis is another drug given to the patient. So our next presentation, inshallah, we'll start talking about drugs which are used in treatment of ischemic heart disease, especially the angina pectoris and myocardial infarction. I would like to thank you very much for your attention. Please don't forget to subscribe to my channel. تقبل الله منا ومنكم الصيام والقيام والأعمال الصالحة. I wish you happy Eid. والسلام عليكم ورحمة الله وبركاته.